Welcome, and thank you for joining us today. My name is Ellen Wilson, and I'll be the moderator for this expert briefing for the media, which is hosted by the Johns Hopkins Bloomberg School of Public Health. This month, we mark the second anniversary of the COVID-19 pandemic declaration. We've come a long way in many parts of the world, but still have far to go. Today's experts will provide insights on what we might expect in the third year of COVID-19, including insights on the BA.2 subvariant on vaccines for children and the general public, and Ukraine's public health situation. Please note that participants are welcome to use images, video, or quotes directly from the briefing, and that the content is for immediate release. First, I'd like to briefly introduce our two speakers. Dr. Anna Durbin is trained in internal medicine and infectious diseases and studies experimental vaccines for SARS-CoV-2, dengue, West Nile, Zika, malaria, and more in human clinical trials and in controlled human infection studies. She is a professor of international health and serves as the director of the Center for Immunization Research at the Bloomberg School. Dr. Amber D'Souza is an infectious disease epidemiologist and studies prevention, natural history, and screening for infections, such as human papillomavirus, HIV, and SARS-CoV-2. She is a professor of epidemiology at the Bloomberg School and principal investigator of the longest study of HIV in the US. We will have time for questions following our speakers' remarks. The procedure will be as follows. We will take some questions that have been submitted in advance of the briefing and some questions from the Zoom chat. If you have a question during the briefing, you can enter it in the Zoom chat addressed to all panelists. Please enter your name, media outlet, and question. We hope to cover as many as possible. Just a note that participants will be muted during this briefing and it will be recorded. Dr. Durbin, please go ahead.
Thanks so much, Ellen. Welcome to everyone today. I'm going to start by talking a little bit about children and vaccines. In February, the FDA said that they would wait for more data to determine just how well 3 doses of the Pfizer-BioNTech coronavirus vaccine works in children younger than 5 years of age before deciding on whether or not to authorize this vaccine for this age group. Now, the Omicron wave led to a higher infection rate in this age group of children in the vaccine trial, which was a bit unexpected. The company is now evaluating a 3rd dose as part of the primary vaccination series for this age group, which includes children 6 months to younger than 5 years. It was recognized that this was a disappointment to many parents, but I think what I want to highlight is that this really does demonstrate the data-driven development and approval process that have been used for the COVID vaccines. The company hopes to be able to submit data to the FDA in April for authorization in this age group. I think excitingly, yesterday, Moderna announced that it would also seek emergency use authorization for their vaccine for children younger than 6 years of age. Early results from their trial also showed the vaccine was less effective in preventing symptomatic COVID in children younger than 5, and that they may need a 3rd dose as part of their primary vaccination series as well. We're hopeful that Pfizer will get an approval sometime in April for their vaccine. It will probably be a bit longer for Moderna as they have yet to submit their data for emergency use authorization. And I want to transition now a little bit to vaccines and Omicron because it has been in the news quite a bit for the past few months. Good news is that Omicron cases in the US continue to decline. While the vaccines appear to be less effective at preventing infection from Omicron, I want to stress that they are still highly effective at preventing severe disease and hospitalization from both the BA.1 and BA.2 strains of Omicron. Although protection against infection did wane over time and with the Omicron surge, booster doses were highly effective, increasing vaccine effectiveness against both infection and severe disease. The greatest protection against hospitalization and severe disease was seen in those people who had been boosted. A subvariant of Omicron, strain BA.2, has been in the news recently as well. This variant appears to be more transmissible than the original BA.1 Omicron variant, but also it appears to cause less severe disease, which is good news. As mask mandates are lifted and people return to in-person activities, we will likely see an increase in COVID cases. I always say that vaccines are somewhat a bit of victims of their own success because they were so effective against infection caused by strains earlier in the pandemic, raising expectations that they will prevent reinfection for the long term. These vaccines continue to be highly effective in the prevention of hospitalization and severe disease. I want to stress that neither vaccination nor infection will prevent COVID reinfection forever. COVID is here to stay. But I think it's important to note that persons who do not have immunity to COVID are those who are at greatest risk for infection and severe disease. For this reason, it's so important that if you haven't been vaccinated, you go ahead and get vaccinated. And if you haven't yet been boosted with your third dose of vaccine, you should get your booster dose. These will help protect against COVID and Omicron. Thank you.
Thank you, Dr. Durbin. Now we will hear from Dr. D'Souza. Dr. D'Souza, please go ahead.
Thank you. As I look ahead at what we expect in the coming months, there is a new variant of concern, BA.2. We know BA.2 is highly contagious, 50 to 60% more transmissible than Omicron. And initial data suggests that BA.2 has a reproductive rate, or R0, around 8 to 12. This is a high reproductive rate, similar to that of chickenpox, meaning each infected person infects many other people. The BA.2 variant is already the dominant strain in some European cities and now makes up around a third of cases in the US this week, up from a quarter of cases last week. The good news is that BA.2 does not cause more severe illness than earlier strains and does not appear to evade immune responses from COVID vaccination or prior infection. So we expect BA.2 will lead to increased infections in the US because it is more transmissible. But given the population immunity we have, we do not expect the surge in severe illness to be as large as that seen in previous years. 2 years into the US COVID epidemic, we now have many tools to allow a return to a more normal way of life. Kids are back in person in school, mask mandates have been lifted in many areas, and people are returning to work. Government investment has provided free access to COVID vaccines, booster shots, testing, and high-quality masks. New COVID therapies have improved survival. The majority of the US population now has immunity to coronavirus through vaccination or natural immunity, leading to a transition this year to an endemic stage of infection, where we learn to live with COVID. But the threat from COVID is not gone, and we are seeing new surges of infection with BA.2 across Europe and Asia that are likely to happen here as well. Other global events also affect COVID transmission. Right now, the violence in Ukraine is creating a threat to public health that is likely to lead to increased COVID transmission in the region. Before the invasion of Ukraine, they were experiencing an Omicron surge in cases with the highest rate of coronavirus Ukraine had seen occurring in the month right before the invasion. Only a third of Ukrainians are vaccinated, so the population is still highly susceptible. The societal disruption from the invasion of Ukraine creates a high-risk setting for coronavirus transmission. Current environmental factors such as crowding and reduced access to healthcare in Ukraine foster COVID transmission. Crowded indoor spaces like refugee camps are often breeding grounds for infectious diseases like tuberculosis and COVID. Population movement of refugees fleeing also increases the spread of infection by those who are sick. Public health response is hampered by the violence. Testing and surveillance is limited, and prevention methods such as distancing, masking, vaccination, and quarantine of cases will be challenging. Infectious diseases exploit these opportunities to spread exponentially, and we expect to see outbreaks of COVID as well as other infectious diseases stemming from the invasion of Ukraine. So what comes next? In this third year of COVID in the US, infection rates should begin to become more stable and predictable. There will still be future surges of COVID, and this may require re-implementation of some mitigation strategies, such as social distancing and masking. But future surges are unlikely to cause as much severe disease as we've seen these past 2 years due to the population immunity that we now have and important tools such as vaccines, boosters, and antivirals. Immunity can wane with time and with viral mutation, so future COVID booster shots may be needed. We also need to be prepared for the next pandemic. We need to invest in our public health infrastructure and disease monitoring now so that we can be better prepared when future crises strike. Thank you.
Thank you so much, Dr. D'Souza. Now we will take questions. If you have a question, again, a reminder, please enter it in the Zoom chat with your name, media outlet, question, and to whom you'd like to address your question. Here is the first question from Barbara Britt at WMAL Radio in DC for Dr. D'Souza. How real of a threat is this latest variant, and will there be more shutdowns?
BA2 is a real threat because it is more transmissible, so it's easier to spread, and I do think it will lead to increases in infection. However, because it does not cause more severe illness than previous variants, I do think there is a lot of hope with the population immunity that we have, that what is to come is not as bad as what has come, but it still can make you sick, and there still will be severe disease.
Thank you. And a follow-up to that from Charlie Schmidt at Scientific American. For you, Dr. D'Souza, what do you expect in terms of a significant bump in hospitalizations and deaths, or whether vaccination and/or prior Omicron infections will provide some immunity?
The initial data that we have suggests that this variant we do have protection from immunization and previous infection to this variant. That protection is not as good as the protection to the original variants, but it still is good against severe disease. However, while we have that protection and immunity, we do know that the more infection that is spreading, even if a small proportion of people are developing severe disease, when infection is rampant, that small proportion can grow in number and it can overwhelm the healthcare system. So I think we're going to have to look locally. In some places, the surges may not overwhelm hospitals and may not be bad, and in others they may. So we'll need to consider not only what the infection rate is, but what is happening with severe disease and our hospital capacity in deciding what local responses are needed.
Mm-hmm.
And another question for you, Dr. Durbin. Are we just doomed to get ever more transmissible variants, or is every new variant by definition more transmissible in a population with partial immunity?
Well, that's a great question. I always liken it to these viruses are really, it's survival of the fittest. It's sort of evolution in action, meaning that if a variant is going to take hold, it has to outcompete the other viruses that are there. Part of that competition or out-competition can be being more transmissible. It can be that the virus, for instance, another mechanism will be it stays longer. So it's really difficult to say whether they'll be more transmissible or whether these viruses will just find other ways to infect people who have some immunity. I don't think that variants by definition are more transmissible in a population with partial immunity. I think what we're seeing really is the evolution of the virus. So 2 years ago, it was new to the human population. It's adapted to live with us, live among us, and spread among us. So it's hard to tell if each new variant will be more transmissible. We had other variants, for instance, that were less transmissible. So I don't think we can say that it's something that's going to happen again and again. What I can say is we will see new variants. Some may be more transmissible. Others may have other characteristics about them, so it's difficult to say. But our greatest protection against new variants really is getting population immunity, and that's preferable through vaccination as opposed to infection.
Great, thank you so much. Here's a question from Drew Armstrong at Bloomberg News for Dr. D'Souza. Given the prevalence of at-home testing, how much can we rely on reported test numbers to identify new waves?
Yeah, this is a great question. Early on, when we did not have at-home testing, we didn't have enough capacity. So even then, we were undercounting the number that were sick. Now we have at-home testing, and we know that we are undercounting the official numbers because the at-home tests are usually not counted. So I think what we see for the number of tests is that it's a lower threshold, and we know there is more testing that is occurring. But we can look to the number of the hospitalizations, severe illness, and deaths as the outcomes, as well as percent positivity among those going to testing centers. All of those give us indications to monitor where things are for the pandemic.
Great, thank you. Here's a question from Adriana Rodriguez at USA Today for Dr. Durbin. Moderna announced Wednesday it plans to apply for emergency use authorization of its vaccine for kids 6 months to 6 years in the upcoming weeks. Pfizer says it should have data on kids under 5 in early April. So when can parents expect to vaccinate their younger children? Will young children be protected by the time BA2 takes over and there's another surge, or will we be behind the curve?
That's another great question. Well, I will say that our regulatory agencies, both the FDA and the CDC, work very quickly once they receive the package from the company asking for emergency use authorization. So I would expect if Pfizer submits their package to FDA in early April, it will be reviewed very quickly. Typically, it's been reviewed within a week or two of submission. And then the CDC's Advisory Committee on Immunization Practices then meets within a week or two after that to make recommendations on vaccination. So I think that if that package is submitted in early April, we'll have an EUA. If it is approved, we'll have an EUA certainly by the end of April, if not a bit earlier, for the Pfizer vaccine, which I think is good news. Whether or not that's in time or we're behind the curve, I think we still have to see. I mean, I think what's encouraging is we continue to see COVID cases go down, which is good. We haven't seen a new surge begin. It is a matter of time and it's sort of a race, but I'm very confident that FDA and CDC, once they see the materials from Pfizer and Moderna, will work very quickly toward approval if the data indicate these vaccines should be approved for those age groups.
Great, thank you. Here's a question from Marie Rosenthal at Infectious Disease Special Edition for Dr. D'Souza. What about mask wearing? CDC says we don't need them. Do you think we should be still wearing them in public places? What about schools?
This answer is not a one size fits all. Earlier in the pandemic, we were really making decisions together based on public health for all. As the risk has gone down, we're now making more individualized decisions. Rates of infection are low right now in the US, and risk of infection, if you are someone who has immunity, if you've been vaccinated or had natural infection, your risk of severe illness is low. So in most places in the US, you do not need to wear a mask given that low risk. However, if you're a person who's at increased risk or a person who does not have immunity or lives with someone in that case, additional precautions are needed. In addition, we all have a different risk threshold. So given the same risk level, some people are going to feel very comfortable going into a restaurant or into a grocery store without a mask, and other people are not. So I think instead of it being mandated now, there's a differentiation where the onus is more on the individual.
Great, thank you. Here's a question from Sean Radcliffe at Healthline for Dr. Durbin first, and then Dr. D'Souza. The White House said this week that absent additional funding approval from Congress, the administration has run out of money for COVID testing, treatment, and vaccines. How will this funding shortfall impact the United States' ability to respond to the pandemic going forward, including addressing another possible surge?
I do think the lack of funding will have a large effect on control of the pandemic. You know, I want to stress people, throughout the past 2 years, the vaccines, because these vaccines were paid for with taxpayer dollars, have been free to everybody who wants a vaccine. Testing has been free to people who want a vaccine. So these mitigation measures have really been funded by the government and gotten us to a point now where Dr. D'Souza just said, we don't need mask mandates now. This is more of an individual finding. I think without that funding, while we're still in the midst of Omicron and COVID, and we're not entirely back to normal yet, there are concerns that we could have another surge. Lack of funding to address that could really adversely affect our response to the pandemic. And not just this pandemic. I think, we've had previous examples where we were concerned about pandemics, whether it be from another H1N1, another avian influenza virus, SARS-CoV-1. And we realized that we didn't put the money into prevention that we could have at the time. And so when COVID came around, we were not prepared. So now is not the time to back off on funding. Now is the time to really cement that funding and think about the future and prevention, not just of COVID, but of future pandemics that are surely going to come.
Great. And Dr. D'Souza, anything to add to that?
I agree. We have the tools that work, and we know that if you have to pay to use those tools, it is a barrier. Mm-hmm. And when I walk into the grocery store and someone sneezes or coughs in the aisle next to me, I don't want to worry that they didn't have the $10 to spend on an extra test and came into a congested setting without testing that they might have done if it was available free of charge.
Great, thank you. Here's a question from Andrew Joseph at STAT for Dr. D'Souza. Thinking beyond whatever spike BA2 does or doesn't cause, how do you see the future fluctuations in cases? Will we ever get down to actual low levels of virus or even some in between waves? Will there be some plateau?
I am very hopeful about what the future holds. And the question is how long it takes to get there. We will see a stabilization where this, has surges, and it may be seasonal, but it is within an expected range. And I don't know that that will happen this year, but I'm confident, if not this year, next year, as we continue to build immunity and get enough people to get booster doses, that we will get there. It is a very difficult question, how many deaths is too much and what is a low level. And, we have these tools to drive infectious rates lower, but there's not as much appetite for continuing to practice some of those prevention measures. So we may have a sustained level of severe illness that is higher than many of us in public health would like to see. But I do think the worst is behind us in the US. We do really have made incredible progress, and I'm very hopeful for what is to come this year.
Great, thank you. Here's a question from Christina Vallega at Chalkbeat for Dr. Durbin. As schools peel back COVID mitigation layers, such as masking and quarantines, how can or should school district leaders keep tabs on whether the virus is spreading in schools and whether classrooms remain safe?
That's another good question. I think what's important to note is, one, we can continue testing. So in the schools, it's basic public health measures. I'll say public health 101. We can still keep distance in schools. We can have good ventilation, encourage hand washing, respiratory etiquette, meaning, don't cough into your hands, cough away from people. Stay home when you're sick and get tested if you're sick. Test the kids if they have symptoms and send them home. I think it's something we really learned with COVID, and I think needs to be enforced, not just for COVID, but for other respiratory viruses during flu season. If you have signs of any infectious illness, stay home. Now, I know kids have runny noses all the time and coughs all the time, but it really is important that they at least be tested before they return to school to ensure that they're not carrying illness back into the schools. So I think, we can just, as I said, encourage what I would say are standard public health measures in terms of hand washing, ventilation, distancing if possible in the classroom, and just stay home when you don't feel well, get tested, and don't go back to work if you're infected.
Great, and a follow-up for you, Dr. Durbin. Given plateauing and generally lower vaccination rates among children, what works when it comes to convincing parents to get their children vaccinated? What role can and should schools play in boosting these vaccination rates?
Well, there's a couple things about getting vaccinated. One is acceptance of the vaccine, and one is access to the vaccine. So I think convincing parents to get children vaccinated, convincing anyone to get vaccinated is really a series of conversations from people that they trust. And whether that's their children's teacher, their physician, their pediatrician, having those conversations to give people confidence in the vaccine. And then access to vaccines, we saw that with COVID, I think quite well. If you can improve access, if you can get a vaccine at your CVS instead of having to make an appointment in your doctor's office, that would be great. So vaccination clinics in schools where kids can easily, as part of their school day, get vaccinated. Those are a couple things that I think would really, that in ways that schools can play a role in increasing booster vaccination rates, or even vaccination rates of children in general.
Great, thank you. Here's another question from Marie Rosenthal at Infectious Disease Special Edition for Dr. Durbin. Other countries are recommending a booster for those 65 and older. Do you think the US will also recommend a second booster? And Dr. D'Souza, also for you to comment on this as well.
I think we need data. And I say this all the time. These decisions around booster doses should be data-driven. They should not be driven by the pharmaceutical company telling us when we need a booster. So what does that mean? I think Dr. D'Souza alluded to it a little bit earlier, and that is, I think the first thing that we have to look at is what is a metric we should be using for vaccine and for booster doses. Infection is not really the appropriate metric because, as I said earlier, we're going to see reinfection. Most of our antibodies are in our bloodstream and the virus enters through the nose. What we really look for is protection against severe disease, hospitalization, healthcare provider visits, those measurable metrics that we can follow. If we start to see an uptick in the severity of disease in those 65 and older, that would certainly be a measure where we would say, yes, I think a booster dose is recommended. But I think it's really too soon to tell. As I said, cases are going down. If cases start to go back up, I think we're going to be looking very carefully at those 65 and older. But I also always stress that the timing of your booster dose is very important. You want to get the maximum benefit out of that dose. And if you get boosted too early, your antibody titers have already started to wane, and that may decrease the effectiveness of the vaccine. And we certainly saw that in people, elderly people, for instance, who got their third dose, their booster dose, very early over the summer. And then when Omicron came, they weren't as well protected. So I do think you really want to look at cases. You want to see how the virus is behaving, what the cases look like in terms of severity, and go from there. It's not a perfect metric because you have to follow and see in different age groups, are we starting to see an uptake? But it's really data driven, and I think that's important because it will give people, if a booster dose is indicated in whatever age group, it'll give them the best shot of getting that booster dose at the appropriate time to get the maximum benefit. And that's what's really important.
Thank you, Dr. D'Souza.
Yeah, I would agree. More is not always better. So we do need to have the data to answer this question. For the first booster, the third shot, the data is resoundingly clear. We know it is very helpful in protecting against severe illness. The question of whether a second booster or a fourth shot will be needed is something that the data will be able to answer. Is it needed for everyone? Is it needed for a subgroup? And after what time interval are the questions we have to ask? But what we know about many infectious diseases and immunology suggests for those most at risk, next winter when we expect rates to increase and risk to be high, they may need an additional shot if the data suggests that will protect them. And we'll know that answer in time for the winter surge.
Great, thank you. Here's a question from Ileana Block at WUSA 9 for Dr. Durbin. Will those who were infected with Omicron during the last wave be protected from reinfection with BA2?
So that it's all a matter of time. So, in the long term, no, probably not. As we see, whether you're infected with Alpha, Beta, Delta, Omicron, all of those, your antibodies at the site of infection wane over time. Antibodies are your first line of defense. They prevent infection. The rest of your immune system prevents you from getting severely ill. So as those antibodies wane, it's easier for you to get infected. So yes, over time, they likely will not be protected from infection, but that doesn't mean they won't be protected from disease. And that's really what our metric for vaccines is we want to prevent that disease. Whether you're infected with, as I said, infected with the virus and you get immunity, or you're vaccinated and you get immunity, it's unlikely you're going to prevent infection forever. That's going to wane over months, 3 to 6 months probably, but you likely will be protected from severe disease.
Great, thank you. And our last question of the briefing for both experts, but let's start with Dr. D'Souza. This is from John Lee at WYPR News. What precautions are you personally taking now? Masking in public, not shaking hands, not eating out, etc.
My own precautions vary very much with the risk level of where I am. So a month ago, I was still masking indoors in any setting. I was getting together outside or with small groups of vaccinated friends inside. However, this month, rates are very low where I live. And I have started going into inside settings without masks. My workplace, my kids' school have all dropped their mask mandate very recently. And it's appropriate based on the level of risk where we now are.
Yeah.
Dr. Durbin?
Very, very similar. I also don't mask when I go into buildings, when I go to restaurants, I've been eating out. I will say when I travel, particularly I'm planning a trip to Europe next week, I may wear a mask because rates are higher where I'm going. So it really is situation dependent, but I'm going with friends outdoors, we're going to restaurants, and I feel very comfortable in those settings without a mask. If I visit though, if I'm planning to visit an immunocompromised friend of mine, I may take more precautions when I'm over there, just because I want to make sure that I'm not putting anybody else at risk.
Great. Thank you to Dr. Durbin and Dr. D'Souza for your presentations and insightful answers. We will email the links to the resources mentioned today and shared in the chat. And with that, I'd like to say thank you again to everyone for joining us today.
Thank you.
Thank you.